right, good morning, everybody. We are going to go over some basic, history and physical stuff for pediatrics to start with. When we look at our peds EMS volume, it's a little less than 10%. So we're going to review some of the basics just because it's not a huge part of your volume. And then we're going to go over two cases that we have seen recently to review SVT and tetralogy of Fallot. So we're going to start with heart rate. And so if you look at this, this is a quick way to figure out what a normal pediatric heart rate for that patient's age is. My volume is a little low. I'm getting closer. Is that better? So 150 minus 5 times their age in years. And then if you look at cardiac output, it equals heart rate times stroke volume. And really, we put this up here to remind you that kids really can't change their stroke volume much. They're really dependent on heart rate. So that's why when you see kids get sick, they're so incredibly tachycardic. And then when we talk about blood pressure, you guys all know this, right? Age times 2 plus 70, and then match systolic age times 2 plus 90. And then under 1 year, this is really when we get into trouble. We recently did some competencies and some scenarios, and people were a little bit surprised how low a young infant, especially a preemie infant's blood pressure can go. So just keep in mind, under a year, their systolic blood pressure 70 to 80 is what we consider normal. And then our preemies, really, sometimes you see their systolic blood pressure is in the 60s. And then the important part about this is to remember that you need to use the right size cuff. So a quick way to figure out what size cuff is you're going to turn the cuff long ways. So you're going to hold it almost upside down and straight, and you're going to put it against their upper arm. And if that cuff covers about 40% of that mid-arm, then that's the right size cuff. And then when we talk about respiratory rate, there's no, unfortunately, I don't have a mnemonic for this or a calculation for this. You're just going to either have to remember it or, get yourself a cheat sheet. If you use Hands Heavy or have the guides from the state, you'll be able to see what their respiratory rate is. Keep in mind, when we talk about respiratory rate, we really are more concerned with sort of their work of breathing, their retractions, their flaring, their grunting, whether they're having stride or head bobbing and color changes. And then when we talk about cardiac versus respiratory issues, when we have a cardiac kid who has an increased respiratory rate, we typically describe these kids as silent tachypnea. So they're fast respiratory rate, but they're relatively quiet. So they're not grunting, they're not making all of those accessory noises that we see with our respiratory kids. So those kids, we typically describe them more as noisy tachypnea. So we're getting into bronchiolitis season, you're gonna see these kids and they're making a lot of accessory noises. It's one of the things that can help us sort this out. And then I just want to mention pulse ox, because this is one of the things that we really struggle with in a pediatric patient. If you're trying to rely on their pulse ox, especially if you're trying to rely on it for heart rate and things like that, this may or may not be accurate depending on the size pulse ox that you have on this patient, where that pulse ox is, and sort of how that pulse ox is attached. So you really need to make sure that these kids are still, they have the right size pulse ox on. We often tape it to their foot, like you can see in this picture. The other thing you can do is put a sock over it. And then especially young infants, their hands tend to be cold. So if you're putting a sock over this kiddo, his foot is not warming up, or you're having trouble, you can switch it to the earlobe. And then the important thing, and we'll go through it when we talk about our cases, is really asking the parents, the caregiver, the home health nurse, whoever takes care of this kid, what their baseline is. Because If you see a kid whose pulse ox is 84, 85, and are starting to freak out, but that's where that kid lives, we might start doing some interventions that that kid doesn't necessarily need. So really, one of the first things I ask when I see a kid with a cardiac history is, what is that kid's normal baseline? Are they on oxygen at home? And if they are on oxygen at home, has there been an increase in their oxygen recently? So these are a couple of pictures of a young infant with cyanosis. And so just take a second to look at this kid. You can see that he's a little bit blue around his mouth, and then clearly his feet are a little bit blue. And I put this up here because we are often fooled in young kids, especially preemies, about this acrocyanosis, right? So acrocyanosis is confined to the hands, feet, and circumoral area. This is a good shot. When you look inside this kiddo's mouth, his tongue is nice and pink, it's nice and red. So that is not a kid that has central cyanosis. If you look at this kiddo, his pulse ox is normal, assuming you can, put it on his earlobe or somewhere other than that purple foot. A lot of times, like I said, we'll put a pulse ox on that foot, put a sock over it. Sometimes we'll put some warmer pads on it, a heel pad that you would use to start an IV over that area and see if we can warm that foot up a little bit. This really has to do with how immature these kids' vasomotor system is. So it's typically worsened by cold temperatures. If it's in the winter and this kid is undressed, if mom's changing a diaper and this kid got naked, if this kid's getting a bath, this is often when we notice these things. Otherwise, this kiddo appears well, and it's one of the ways that you can sort out, is this acrocyanosis or true cyanosis? Really important to look inside the mouth, warm up those hands and feet, see if it goes away. And then just like everything else in pediatrics, history, history, history. If this kid is otherwise well and they just notice this peripheral cyanosis tonight, chances are that it's acrocyanosis. And the last sort of basic thing that we're going to go over before we start their cases is just, we're going to talk about quickly IV fluids and medications. This is an article from 2013 from the American Journal of Emergency Medicine, which outlined a hand counting method. So people are always asking about, how do I remember how much a kid weighs? Clearly, you should be using a Braslo, you should be using hand tebby, you should be using some other device that helps you figure out your doses. But if you are trying to figure out, quickly how much this kiddo should weigh, a 1-year-old should weigh about 10 kilos. A 3-year-old should weigh about 15 kilos, and so on. So this is a quick way for you to get a kid's age and sort of estimate what their weight is really quickly. Okay, and so we're going to start with pediatric EKGs. And I put this up here. Take a minute to just look at it for a second. I will leave it up for a minute. And we're going to talk about the differences in pediatric EKGs, especially in infants, because some of these things that you will see in a pediatric EKG are going to make you nervous because they look particularly different than adults. So when we talk about, especially the infant heart, their forces are kind of opposite, right? So if you think about an adult heart, that left ventricle is much bigger, much stronger than the right ventricle. When you think about an infant's heart, right, their pulmonary pressures when they're in utero is really high. So that right side of the heart is actually bigger than the left side of the heart. And it takes a little bit for that right axis deviation to go away. So when you look at this kiddo's EKG, this is an infant, you can see the increased R wave in V1 and V2, and then you're going to see the decreased R wave in V5 and V6. So this is a little bit different than when you look at an adult or an older child, right? You normally like to see that nice R wave progression. You are not going to see that in a young infant. So just keep that in mind when you're looking at these kids. The other thing that you're going to look at that are a little bit different is T waves. So the T waves start out upright at birth, and then they invert during the first week. And so you can see our inverted T waves. And everybody gets a little bit nervous when you see those. This is completely normal. And then they eventually go back to normal by adolescence. And so these things, there's no particular, I can't tell you an exact cutoff for when this happens. It depends on the kids, whether they were a preemie or not, and what else was going on in utero. But these things will eventually go away. So you need to look at these kids, consider their age, and not let these things sort of distract you. They are often normal. What is abnormal in infants, like I said, is left ventricular hypertrophy. So these kids, their right side's actually bigger than their left side. And if you're starting to see LVH in an infant, you need to be concerned. Okay, so we're gonna start with our first case. And this is actually a kiddo that I saw probably about a week ago. They called me late at night to come up to the PICU. So I have altered this case a little bit so it could be a little more EMS friendly, but the facts are the same. So this is a 5-year-old male that was having what they thought was respiratory distress. This kiddo, full-term healthy kid until about a week ago, well, presented to the emergency room because grandma was watching him sleep and she noticed that he turned blue and that he wasn't breathing. So when he came to the emergency room, he was diagnosed with sleep apnea and he was scheduled to have his tonsils and adenoids removed the following week. He went outpatient surgery. Unfortunately, he had some complications afterwards. He had some post-obstructive pulmonary edema and wound up in the PICU, getting some support, getting some oxygen. He needed some Lasix post-out. He was sent home. Mom noticed that he had a fever of 101. She said that he wasn't able to eat or drink today, and he was having a significant amount of pain, but she wasn't able to get him to take his PO meds, which is actually, this is a classic case for these kids that have had tonsils and adenoids. If you get behind on those pain medications, it's really hard to catch up, and it's really hard to get these kids to drink again. Mom and grandmom said there's no cough, there's no runny nose, just they noticed that this kid was breathing funny. They also said that there's really no COVID exposure, and he had a COVID test before his surgery that was negative. So this is this kiddo's vital signs. And so he had a temp of 101. His heart rate was 236 when I saw him upstairs. His respiratory rate was 34. His blood pressure was 116/73. His pulse ox, he was 100% on room air, and he weighed 25 kilos. So when you look at this kiddo sitting in the bed, he's really sweaty. He is breathing funny, and he is a little bit sleepy. If I ask him questions, he does wake up. He does sort of look at me. He gives me sort of one-word answers. It's a little difficult to assess whether that's because he's having so much pain from his tonsils and adenoids, or whether there's really a significant mental status change. Chatting with mom, she says this is kind of how he's been today, and she thought that this was really related to his pain and that he didn't want to talk, and that he seemed pretty with it to her. So like I said, the physical exam on this kid, he is just sweaty, 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 answering questions. We'll look at you. This is his EKG. So I'm going to leave this up there for a second for you guys to take a look. And normally we would have a discussion about this. This is a little bit challenging virtually. So when we go through EKGs, really for this kid, you want to look at his rate, right? And so this kid's rate, we already know from his heart rate, he was 236. And so clearly this kid's rate is very fast. It looks relatively regular, right? It's narrow, complex. And then the other thing we want to do is we want to hunt for P waves. And so looking for P waves will help you decide between sinus tach and SVT. Also, the rate will help you a little bit. So this kid's rate was above 220. And if you look, you don't really see any P waves. So this kiddo was clearly having SVT. When we talk about SVT in pediatric patients, our cutoff for the rate in children is greater than 180. It is different for infants. And so this is sometimes where we get a little bit tripped up, right? Because we talked about their heart rate earlier on, about what a normal heart rate is in a pediatric patient. Their heart rates are much higher than you're used to seeing, especially in infants. Infants that are sick, that are febrile, that are dehydrated, a heart rate of 160, 170, 180 even doesn't make me nervous. It's really when we start to get to that 220 range that you want to be worrying about these infants. We talked about P waves, and if you sort of, depending on what you read, SVT, they will say P waves are absent. I will challenge you to say that sometimes P waves are there in SVT, they're just abnormal, depending on what that kid's underlying issue is. So when you're hunting for P waves, if they're absent or there's only P waves in some leads or they look abnormal, it's a narrow rhythm and you're meeting these rate cutoffs, you really need to think about SVT in these kids. And then our treatment, really, it depends on whether or not this kid was stable or not stable. And so that's why we spent so much time, take a second, get a blood pressure on this kid, look what his cap refill looks like, take 2 seconds and talk to mom and see, is he at his baseline or not? And then we'll go through sort of stable versus not stable for SVT. So this kiddo, we put him in a stable compartment, right? We looked at his blood pressure. His systolic was 116. He was awake and alert and sort of nodding and answering questions. He had a good cap refill when we looked at him, despite the fact that he was ridiculously sweaty. They tried to have him squat on a bedpan. They tried to have him blow in a straw. These methods were really unsuccessful. This kiddo had a hard time cooperating because he was in so much pain from his post-op TNA. So he wound up getting adenosine 2.5 milligrams IV, which is appropriate for his weight, right? We'll talk about in the next couple of slides about the dosing for that. And then if you look at this kid afterwards, this is what his EKG looks like. So obviously the rate is much slower. You do start to see some P waves here. His blood pressure was still fine after all of this. And you guys know this, but when you give adenosine, right, you're going to see that little brief pause. So it makes people particularly nervous in pediatric patients. I just reassure you that's normal. So this kiddo had a little brief pause. You still want to be prepared to resuscitate these kids in case that pause is a little bit longer than you like. But this kid, a couple of seconds after that adenosine had a little bit of pause in his EKG, but we waited, watched, monitored him, and he came right back. Okay, so treatment for SVT, right? We talked about how these kids were divided up into stable and unstable, right? So stable patients get vagal maneuvers, and we'll talk a little bit about how to do that, especially in infants, right? Because infants can't cooperate, they can't follow directions, but we have a couple of tricks that you can try in infants. There's your adenosine dose, right? Your first dose is 0.1 milligram per kilogram per dose to a max of 6. And you should really be using some sort of device to help you with this. Please don't be doing math when these kids are super sick. So, whether it's hands heavy, whether it's Braslow, whether, it's some other critical care cheat sheet that you use, really important to not be doing math when you're taking care of these kids. And then repeating that adenosine dose. We didn't need to repeat it in this kid. He broke. But I have had a couple of adolescents that were a little bit more challenging and needed to get a second and sometimes other medications to break their SVT. The repeat dose is 0.2 to a max of 12. And then when we talk about unstable patients, right, these are the kids who have significant altered mental status. These are the kids whose blood pressures don't look good. These are the kids whose cap refill looks awful. And these kids, you're going to go ahead and cardio alert them. There's the dose, right? Same thing, just like the adenosine, there's a lower dose to start. If it's unsuccessful, you're going to go ahead and increase your dose. Depending on how awake that kid is or is not, you may want to think about sedation prior to alerting these kids. So you have a bunch of, depending on what your protocols are, I listed them out there for you. Midazolam, diazepam, ketamine, and then don't forget a really nice trick is sometimes we can give a little bit of Versed up the nose to get these kids a little more comfortable. So vagal maneuvers, basically anything that makes your face red. And so that is sort of a quick and easy way to remember things that you can do to try and break this SVT. So older kids, you can encourage them to cough. Sometimes this is not so kind, but sometimes we do this if a kid's not cooperating. You can put a tongue depressor and kind of put it in the back of their throat. And that will actually cause them to gag and cough if they're not following directions. I'll just be careful with this because sometimes they throw up. So that is not one of my go-tos, but if you're really desperate, you can certainly try that. The older kids, the adolescents, we ask them to hold their breath and bear down like they're having a bowel movement. Other things you can do is you can have them blow into a straw. For our infants, they have a great diving reflex. So they're actually ice to the forehead and nose. So you put a little bit of ice. We usually use one of the lab specimen bags, put some ice in it, seal it up. You want to make sure that it's just to the forehead and nose, though, not covering their mouth. I explain to parents what I'm going to do before I do this because it freaks them out. And you leave it there for a minute or so, and it should trigger their diving reflex. If it doesn't work in that first, 60 seconds, 90 seconds, it's probably not going to work, and you're just going to make that kid cold. So go ahead and take it off their face. There was an interesting study in 2015 about handstands for SBT. And it actually, the older kids who were able to do handstands, they actually had some success with breaking their SBT. What we do for infants is we kind of hang their head off the bed, supporting their head, of course. Remember that infant heads are significantly large. They have that big posterior occiput, so you really need to support their heads. But you can kind of slide them off the edge of the stretcher and tip them a little bit upside down and see if that makes a difference. I usually do the ice to the forehead and nose first, although that makes parents nervous. Hanging an infant's head sort of upside down off the bed makes them even more nervous. So these are your choices. Just keep in mind when you're thinking about it, really you want to make that kid's face red. That's how you know that that bagel maneuver is working. If their face is red and the SVT is not converting, then it's time to start thinking about something else. All right, so we are going to go on to our next case. So this is a 4-month-old full-term male, spontaneous vaginal delivery. Mom says he was supposed to have surgery for a heart problem, but they've been having problems with their insurance. So the way it works is typically after infants are born, they are covered on mom's insurance for a little bit or dad's insurance for a little bit. After these kids get a little bit older, they need to be switched to their own insurance. So this is actually a pretty common scenario for us, especially in Camden, when we have some access challenges, that these kids had insurance for a little while. They were seen by the pediatrician or the cardiologist, diagnosed with this issue, and then they weren't able to get back in the system because they've actually lost their insurance and they couldn't get their insurance restarted. So mom says that she notices that this kid's lips turn blue when he cries at home. It usually goes away by itself. She hasn't really thought much of it because it went away and only lasted a few seconds. She said, today he had a little bit of cough and runny nose, and he's been really vomiting all day. She hasn't been able to keep down any bottles. This kid's just thrown up everything she's tried to give him. She tried to give him some Pedialyte, threw that up as well. He also has had some decreased wet diapers that she's noticed. She said right before she called 911, this kid was sort of fussy. He was struggling to take a bottle. He sort of coughed, gagged. He turned blue, and then she thinks he passed out for a few seconds. When you look at him, his temperature's 98, his heart rate's 150, his respiratory rate's 40, and his pulse ox is 85%. He is awake, he's alert. As soon as you get near him or start approaching him, he starts crying and his lips turn blue. So you can see what mom is talking about. When he gets agitated, he definitely is blue. When you talk to mom, she says that his pulse ox is usually a little bit higher than this. She thinks last time they were at the doctor that he was like 88, 89, something a little closer to 90, although she's not exactly sure of the number. So this kiddo has classic episodic cyanosis or hypoxemic attack or TET spell. You will hear all of those terms that we see with our kids with tetralogy of Fallot who have not been repaired. And so this kiddo, that is what the lesion or multiple lesions that he has, and unfortunately has not been back to the cardiologist to get these things taken care of. And we'll go through all of these things. So tetralogy talks about 4. And then Fallot is just the physician that discovered or described this alteration in cardiac anatomy. And really the issue with these kiddos is they get an acute decrease in their pulmonary blood flow. And it really happens a couple of ways. When you look at what's wrong with these kiddos' hearts, the first thing is you see narrowing of this pulmonary valve. So this pulmonary valve is smaller. It doesn't allow a ton of blood flow to get out to the lungs. The second thing that you see is you see thickening of the right wall ventricle. And this makes sense, right? If you're pushing against this high pressure, you're going to get a thickened muscle. It's just like lifting weights. Their aorta is a little bit in the wrong spot. So the aorta is really supposed to be on the left side. These kids often have a large defect between the right and the left ventricle. And instead of that aorta being on the left side, it kind of overrides or hangs out over where this DSD is. So they have some decrease in pulmonary blood flow for a number of reasons. And we'll sort of go through what happens to these kids and what you need to do to fix it. And so these kids, it's all about sort of trying to keep the shunt stable. And when they're crying, it increases that pulmonary vascular resistance, so decreases blood flow. And then this kiddo, he was vomiting all day and so got dehydrated. So it decreases that systemic vascular resistance, right? Because this kid doesn't have enough fluid pumping around. So that combination really worsens this kid's cyanosis. He is already in the high 80s, low 90s to begin with, but then this combination of him crying and being dehydrated makes him more hypoxic. And so a little bit to go into the causes a little bit more, right? We talked about sort of when these kids get agitated, they can have spasmodic contraction of this ventricular outflow. They get sudden changes in their systemic vascular resistance and the venous return to their heart. And we talked about how this affects the shunt. They can get some alterations in their respiratory center. One of the things you'll notice about these kids is that they're breathing very deeply. So they look kind of like they're working out. So if you are on the treadmill and you notice that you're starting to breathe deeper and heavier, that's kind of what these kids look like. They have these changes in respiration. And then they also have changes in heart rate. So signs and symptoms, their cyanosis gets worse. They have a history of heart disease. This kid is obviously too young because he's only 4 months old, but we have had a number of kids who have escaped the medical system altogether. We have actually at Cooper, we have a 35-year-old man who has unrepaired tetralogy of Fallot, who recently we have started seeing, and he comes to us from another country. And so he has obviously all sorts of issues. But the older kids, they will, if you talk to the parents, they will have a history of squatting. So these kids know, and when we go through treatment, these kids know that if they squat and sort of increase their systemic vascular resistance, that they will cause that shunt to go the other way, and they will feel better. They will feel less hypoxic. So if a parent tells you a 4 or 5-year-old is running and playing outside, and then they all of a sudden sit down to squat, that's one of the things that should give you a clue about tetralogy Fallot. And then our infants, they're often irritable, they're crying, they're having difficulty feeding, which pretty much describes this kid. We talked a little bit about the breathing more deeply, right? These kids, it's not necessarily that their rate is faster, although you sometimes can see an increased respiratory rate. These kids are really taking deep breaths. And then when we listen to these kids, if mom says that they have a murmur, some of these parents know that these kids have a pretty loud murmur. That murmur actually may be less noticeable because of that decreased pulmonary blood flow when they're having a hypoxemic attack. What causes these kids to have hypoxemic attacks? Our kiddo was dehydrated and was crying and irritable, so was stressed out, dehydrated. When we look at these kids, they're often morning events, right? When the older kids in particular, when they get up out of bed, their cardiac output changes a little bit. So this kid may have been all fine all night, and then all of a sudden gets up, starts doing an activity, and looks unwell. So we talked about, changing that flow and we want to increase that systemic vascular resistance, but we want to decrease that pulmonary vascular resistance. And so one quick way, and this is usually the very first thing that we try when they get to the emergency room, is if they're an infant, we put their knees up to their chest. If they're really fussy, you can have a parent hold the child like this, and you can see dad's hands are kind of squishing that kid's legs up into their chest. You really want to force them into this position. Keeping them with the parent is important as well. You obviously want to assess this kid, but if they're agitated and crying, you really want to calm this patient down so you can decrease that pulmonary vascular resistance. So giving these kids back to the parents, scrunching them up. An older kid, if they're stable enough, we tell them to get down on the ground and squat. Sometimes we lay in bed, tell them to lift their legs up and see if that makes a difference. And then if that doesn't work, we typically move on to one of these things. So you can give them oxygen, although it's usually not an oxygen problem. It's usually more of a flow problem. And you really need to try and redirect that shunt. So if a kid is agitated, crying, really irritated, it's going to make that shunt worse. So consider giving them some fentanyl, giving them some morphine. This does a couple of things. If they're stressed out, if they're agitated, in theory, it may decrease your catecholamines and may decrease that outflow tract spasm. It may also decrease their ventricular drive. You want to be careful, right? We don't want to decrease their drive too much. So I typically start with a low dose of morphine. So I will often give these kids half of this dose IV and see how they do. If it settles them enough, then I won't redose them, or I won't give them the whole dose. So I often will start at half of a normal dose just to see if I can settle these kids a little bit. And then if you get a history that these kids have had vomiting, diarrhea, they've not been drinking, they're not well, you want to go ahead and give them a fluid bolus. Pay attention that this is 10 mLs per kg, right? When we talk about pediatric patients, the normal bolus is 20 mLs per kg. We start these kids with 10 because they're cardiac kids. You can always give more if they need it. It's a little bit hard to take it back once you've given it. And so really this bolus really pops open that right ventricle and see if we can get past that outlet flow obstruction. You can consider a beta blocker. There's some discussion about whether this affects infundibular contraction, their ventilator response, or their vasomotor tone. I will tell you, most of the kids that I have taken care of, scrunching them up, giving them a little bit of volume, and calming them down usually does the trick. I often don't have to get to this step, but it's here if you need it. And then other things to consider: ketamine, phenylephrine, right? This increases their systemic vascular resistance and decreases that right to left shunt. So it really depends on sort of which one of these you're going to use, kind of depends on their blood pressure, their cap refill, and what they look like. So going back to our kiddo, this kid was put in the knee to chest position, was given to the parent, kind of scrunched up, continued to cry, understandably, because we're all strangers, and especially these days with all of our shields and masks and all of this kind of things. This kid received a dose of morphine, and like I said, we started at half dose, so he got 0.05 milligrams per kilogram. He received an IV fluid bolus, and his pulse ox improved. He looked well. So we didn't have to go any further down that algorithm. We transferred him to DuPont. That was his home base for his cardiac care. So that's the other thing to keep in mind for these kiddos is your destination choice. These kids really, assuming they're stable enough, it's a discussion about, can they get to a children's hospital, or do I need to go to the closest hospital because they're clearly so sick. So these kids can be a little bit challenging when we talk about their destination.